Welcome back to the deep dive. Today, we are really stripping away the generic advice and getting into the weeds.
We really are.
We're doing a kind of rigorous grand rounds session for your ears, and we're tackling the absolute cornerstone of women's health education.
That would be Hacker and Moore's Essentials of Obstetrics and Gynecology, 6th edition.
The one and only.
This book is a beast. I mean that in the best possible way. It's pretty much the gatekeeper text between being a medical student and, well, becoming a competent clinician in this field.
Exactly. And for anyone listening who thinks this is just about delivering babies or, annual exams, you are missing the forest for the trees.
Oh, completely.
The reason we picked this source is that it argues for a total reframe of the field. It moves away from just treating isolated events and pushes for what they call a life course perspective.
That is the headline concept here. Most medical textbooks are organized by disease states. Here's a chapter on infection, here's one on cancer.
Right, the usual layout.
Hacker and Moore organizes it all around the lifespan. The argument is that effective care doesn't start when a patient walks into labor and delivery, and it certainly doesn't end at menopause.
It's a continuum.
A continuum where every single stage influences the next.
It sounds a bit philosophical, treat the whole patient. But the text backs this up with some pretty hard science.
It does.
Specifically something called the Barker hypothesis. This was a standout section for me.
It's one of those concepts that just changes how you view medicine. The Barker hypothesis essentially suggests that the intrauterine environment, so how the placenta develops and functions, it programs the fetus for chronic diseases 50 or 60 years later.
So we aren't just talking about a baby being born small.
No, not at all.
We're talking about programming their future cardiovascular system.
Precisely. If you have poor placental development that leads to low birth weight, you aren't just managing a neonate. You're looking at a future adult who is now, biologically wired for hypertension, heart disease, and diabetes.
Wow. So the obstetrician is effectively acting as a preventative cardiologist for a middle-aged adult, decades in advance.
That's a great way to put it, yeah.
That sets the stakes incredibly high. And speaking of high stakes, the text outlines 4 pillars of practice to manage this responsibility.
Ethical practice, value-based care, prevention, and patient safety.
I want to zoom in on patient safety because they draw a direct line to the airline industry.
Right, the cockpit resource management idea. For a long time, medicine was very, very hierarchical. The surgeon was the captain of the ship, and, no one questioned them.
But in obstetrics, things go south in seconds. You have 2 patients, the mother and the fetus.
Exactly. So if a junior nurse sees a decelerating heart rate on the monitor, they need to feel empowered to speak up immediately, even if it interrupts the senior doctor.
So Hacker and Moore is pushing to flatten that hierarchy.
Completely. It's about standardizing communication, using checklists, and realizing that safety comes from the whole team, not just the brilliance of one person.
Let's take that mindset into the exam room. Section 1 of our dive is the clinical approach and anatomy. The text really emphasizes that history-taking here is a minefield if you aren't careful.
Oh, absolutely. You're asking strangers about the most intimate details of their lives. Sexual history, trauma, incontinence.
Yeah.
If you don't build rapport in those first 30 seconds, you just won't get the truth. And without the truth, you miss the diagnosis. The book offers a mnemonic for pain history old carts.
I feel like everyone learns some version of this in training, but let's refresh why it matters so much for GYN complaints.
It just keeps you disciplined. O for onset, L for location, D for duration. But the C characteristics is vital in gynecology.
Okay, how so?
Is the pain cramping? That points to the uterus. Is it stabbing or sharp? That could be ovarian. Then you have A for alleviating factors, A for associated symptoms, R for radiation, T for timing, and S for severity.
And if you skip radiation, you might miss that the back pain is actually referred pain from the cervix or uterus.
Exactly right. And once you have the history, you have to touch the patient. The physical exam section has some pearls that I think even seasoned pros sometimes drift away from.
You're talking about the rectovaginal exam.
I am.
This is the part of the exam patients dislike the most. And honestly, a lot of doctors skip it to be nice or save time. But the book argues it's non-negotiable for certain complaints.
It is non-negotiable because of the anatomy. The cul-de-sac, the pouch of Douglas, is the space behind the uterus. It's the lowest point in the peritoneal cavity.
And things collect there.
Things collect there. Ovarian cancer often seeds there. Endometriosis nodules live there.
Mm.
If you only do a vaginal exam, you simply cannot feel that space. You need a finger in the rectum and one in the vagina to properly evaluate the tissue between them.
So skipping it means you could miss a mass until it's stage 3 or 4.
That's the reality, yeah.
There's also a very practical, almost mechanical tip about speculum insertion that I found immediately useful.
Directed posteriorly, it's simple anatomy. The urethra is anterior towards the front, and it is packed with nerves, very sensitive. The perineum towards the back is relatively tough and insensitive.
Oh.
So when you insert the speculum, you press downward against the perineum. It changes what could be a painful, sharp sensation into just a feeling of pressure. It's a small technique with a huge impact.
The text also makes a point that our patients aren't all the same.
Yeah.
There's a strong section on inclusivity, particularly for LGBT patients.
And this isn't just about, social etiquette. It's about clinical risk.
Yeah.
The text notes that lesbian, gay, bisexual, and transgender patients often face discrimination that leads to higher rates of psychiatric disorders, substance abuse.
Right.
So if an OBGYN just assumes everyone is heterosexual or cisgender, they fail to create that safe space you need to uncover those specific health risks.
And on the other end of the demographic curve, we have the geriatric patient,
where the anatomy literally changes. You see atrophic vaginitis, thinning tissues, and organ prolapse. You can't just use the same equipment or techniques you'd use for a 20-year-old.
Let's shift gears to the structural side of things, anatomy and embryology. The text takes a little detour back to week 4 of gestation.
Well, you can't be a good surgeon if you don't understand the embryology. Take the adnexa, the ovaries, tubes, and ligaments. They sort of float in the pelvis, but their blood supply and their relationship to the ureters are all determined by how they developed and migrated during those first few weeks of life.
And that anatomy dictates where you cut. The book contrasts the Fanon-style incision with the midline incision.
Right. The Fanon style is the bikini cut. It's that transverse incision just above the pubic bone. It looks great, heals well, standard for C-sections. But, and this is a big but, it limits your view of the upper abdomen.
And why is that a problem?
Well, if you suspect ovarian cancer, which can spread to the liver or diaphragm, you generally should not do a Fanon style. You need a midline vertical incision to explore the entire cavity. You can't prioritize a cosmetic scar over proper cancer staging.
Makes sense. Okay, let's follow the timeline. We've covered the exam and anatomy. Now, section 2, obstetrics. The text makes a bold claim here. Prenatal care shouldn't start when she's pregnant.
No. By then, the major organs are often already formed. Organogenesis happens in those first few weeks, often before the woman even knows she's pregnant or books her first appointment.
So if she has uncontrolled diabetes or obesity, the metabolic damage to the embryo can happen before she ever sees a doctor.
Exactly. So that before pregnancy screening tool is actually the most high-yield intervention. Preconception health is where the real preventative medicine happens.
But of course, not every pregnancy lands safely in the uterus. We need to talk about ectopic pregnancy.
This is a major cause of maternal mortality. An ectopic is an implantation outside the uterine cavity, usually in the fallopian tube. As it grows, it ruptures the tube. Internal bleeding can kill a patient in hours.
So what's the red flag? The text outlines a classic triad.
Missed menses, vaginal bleeding, and lower abdominal pain. If a woman of reproductive age walks in with those 3 symptoms, you have to think it's an ectopic pregnancy until proven otherwise.
And how do we prove it?
You need to correlate biology and imaging. You check the pregnancy hormone quantitative HCG. If that level is high enough, above a certain discriminatory zone, you should see a pregnancy sac in the uterus on a transvaginal ultrasound.
And if you see an empty uterus with high hormones?
Then the pregnancy is likely hiding somewhere else. And that's your diagnosis.
Now, assuming the pregnancy is safe and intrauterine, we eventually get to labor. I found the definition here really strict. It's not just pain and contractions.
And this is a crucial distinction because admitting a woman too early leads to a cascade of unnecessary interventions. True labor requires regular uterine contractions, at least every 3 minutes, plus documented cervical change.
Cervical change being the absolute key.
Right. If she's contracting but the cervix is closed and thick, that's false labor. It hurts, but it's not physiologically effective yet.
And that strict definition applies to preterm labor too.
Correct. Preterm labor is between 20 and 37 weeks. We don't diagnose it just on cramping. We need to see 80% effacement or more than 2 centimeters of dilation.
Because the treatments have risks.
Exactly. The drugs we use, magnesium sulfate to stop contractions, steroids for the baby's lungs, they have side effects. You don't want to use them unless it's the real deal.
Speaking of high risks in pregnancy, preeclampsia.
The monster of obstetrics. It's a systemic disease. We look for that classic triad of hypertension, proteinuria, and generalized edema swelling in the hands and face, not just the feet.
And the management always seems like such a paradox. The cure for the mother is to deliver the baby, but the treatment for the baby is to stay inside.
That's the central conflict. You are trying to prevent the mother from seizing, that's the eclampsia part, while buying time for the fetus's lungs to mature. It is a constant tightrope walk.
And just briefly on bleeding third trimester, you have to differentiate placenta previa from abruption.
Right. Placenta previa is where the placenta covers the cervical opening, the exit is blocked. Abruption is when the placenta detaches from the wall too early. Both cause bleeding, but the management is totally different.
Okay, let's move to section 3, gynecology, the non-pregnant patient. The text describes the menstrual cycle not as one loop, but as 4.
Yeah, it's a symphony of 4 players. The hypothalamic cycle, the pituitary, the ovarian, and the endometrial cycle. If any one of them drops the beat, you get cycle disruption.
Which brings us to abnormal uterine bleeding, or AUB. I'm glad to see the text moving away from dysfunctional uterine bleeding.
Dysfunctional is such a lazy term. It tells you nothing about the cause. The book really champions the Paul-Cohen system. It's an acronym, but think of it as a diagnostic decision tree.
Okay, let's break it down because this is probably the most useful framework in the GYN section for a student or clinician. Paul-M is the structural causes.
Correct. These are things you can usually see on imaging or with pathology. P for polyp, A for adenomyosis, L for leiomyoma, which is just the medical term for fibroids, and M for malignancy.
So an ultrasound will usually find those?
Usually, yes. If the Paul-M causes are there, you'll see them.
And if the ultrasound is normal, then you move to CoAM.
The non-structural or functional causes. C for coagulopathy, does she have a bleeding disorder? O for ovulatory dysfunction. E for endometrial issues. I for iatrogenic, did we cause it with meds or an IUD? And N for not yet classified.
I want to zoom in on 2 common conditions here that often get confused, fibroids versus adenomyosis.
Both involve the uterus, both cause bleeding. Fibroids or leiomyomas are benign muscle tumors. They're like distinct balls of muscle. And the rule is, if they aren't bothering the patient, don't touch them. You treat the symptoms, not the ultrasound finding.
Okay, and adenomyosis.
That's different. That's when the lining of the uterus, the endometrium, actually invades the muscle wall itself. It makes the uterus boggy, enlarged, and tender. And it's much harder to treat surgically without just taking the whole uterus out.
And then there's the condition that patients are finally talking about more openly, endometriosis.
Which is that same tissue growing outside the uterus. It's inflammatory, it's painful, and the text highlights a specific physical sign during that rectovaginal exam we talked about.
A barb sensation.
Exactly. You feel a sharp, tender nodule on the uterosacral ligament, like a fishhook. It's a classic sign. But here's the kicker that frustrates so many patients. You cannot diagnose it definitively with a blood test or an ultrasound.
So the CA-125 blood test doesn't work.
It's not specific enough. It can be elevated for all sorts of reasons. To be 100% sure, you have to do a laparoscopy. Put a camera in the belly and actually visualize or biopsy the lesion.
Let's touch on structural failure of the pelvis before we move on. Prolapse.
Gravity always wins eventually. The bladder can drop, that's a cystocele. The rectum can push up a rectocele, or the uterus itself can fall out.
The text mentions precedentia.
That is complete uterine prolapse. The uterus is literally outside the body. And the danger isn't just that it's distressing, it can actually kink the ureters, the tubes from the kidney, and cause kidney failure. It becomes a mechanical obstruction.
Okay, moving to our last section, oncology. What's the one thing a listener needs to memorize about endometrial cancer?
Postmenopausal bleeding. If a woman has stopped having periods and then starts spotting again, it is cancer until proven otherwise.
No exceptions.
No exceptions in your initial workup. You need a transvaginal ultrasound immediately. You look at the endometrial stripe, the thickness of the lining. If it's thicker than 4 millimeters, you have to biopsy.
It's a clear cutoff. I like that. Now, before we do any of these procedures, biopsies, hysterectomies, we have to get consent. And the text offers a great checklist called Prepared.
Which is so much better than just a signature on a form. It makes it a real conversation. P for procedure, R for reason, E for expectation, what's the realistic outcome?
Right.
P for preference, A for alternatives, R for risks, E for expense, and D for decision.
Expense is an interesting inclusion for a medical text.
It reflects the reality of modern medicine. Financial toxicity is a real side effect. Patients need to know what they're signing up for physically and financially.
All right, we've covered a ton. The life course, anatomy, babies, pathology, cancer. I want to put this all to the test with a quick review case.
Let's do it.
Okay. You have a 35-year-old patient. She comes in complaining of heavy, unpredictable bleeding. Her BMI is 35, so she's in the obesity category. She says her periods have been irregular pretty much since she was a teenager. You do a pelvic ultrasound, and the uterus looks perfect. No masses, no fibroids, normal lining. Using the Palm-Cohen system, what is the most likely category?
Okay, great case. So let's look at the Palm side first, the structural side. You said the ultrasound is normal, so no polyps, no adenomyosis, no leiomyomas, no visible malignancy.
Right, so Paul is off the table.
Colin's off the table. So we are in Codian territory, the functional positive.
Okay.
And we have a patient with obesity and a long history of irregularity. That pattern is the absolute hallmark of an ovulation. If she doesn't ovulate, she doesn't make progesterone to stabilize the uterine lining, so it just builds up and then sheds chaotically.
So which letter in the acronym?
That would be O for ovulatory dysfunction. It fits the history perfectly. It's not likely coagulopathy. It's not iatrogenic. It's a metabolic and hormonal issue driven by the adipose tissue.
And that diagnosis totally changes the treatment. You don't need surgery.
No. You need to fix the cycle. Hormonal management or weight loss would be the first line. If you just did a D&C without fixing the ovulation issue, she'd just start bleeding again.
As we wrap up this grand rounds, I want to circle back to where we started, that life course perspective. It really does change how you see that 35-year-old patient in our case study.
It connects everything. Her embryology dictated her anatomy dictated your exam, her current metabolic state, the O in that case, is likely influencing her future cancer risk or her future pregnancy outcomes.
And Hacker and Moore leaves us with a final, and I think somewhat provocative thought regarding that timeline.
They note that up to 40% of premature deaths are linked to behavior and environment. So epigenetics. If we accept the Barker hypothesis that obstetrics is a window into future chronic disease, it raises a massive question for primary care.
Which is, should a cardiologist treating a 60-year-old man be asking about his birth weight?
They probably should be. If that man was growth restricted as a fetus because of placental issues, his heart disease might have been programmed from birth. It challenges us to look at the patient not just as they are today, but as a product of their entire developmental history.
A powerful place to end. We treat the patient in front of us, but we need to respect the biology that got them there.
Couldn't have said it better.
That's it for this deep dive into Hacker and Moore. We hope you feel a little more prepared, pun intended, for your next clinical encounter or exam.
And don't forget your Palm, Cohen.
Thanks for listening. We'll see you on the next dive.